Welcome, everyone, to our session this morning for me, maybe afternoon or evening for wherever you are. It's a pleasure to be here with you today. Just before we begin, just a quick slide on some of the tips on using the platform, which you've probably seen before, but just to take a moment to orient yourself to the platform. For this session today, we will be using the chat and discussion forum quite extensively. So make sure that you have that available to you. So as I mentioned, welcome everyone to the session incorporating gender and equity into human resources for health research and interventions. My name is Rosemary Morgan. I'm based at the Johns Hopkins Bloomberg School of Public Health in the United States, and I'm here with my co-presenters Zara, Shreytush, and Varo, who will all be introducing themselves in just a moment. But before we get to that, just a quick overview of the session today. This session is a skills building session, and if we were together in person, we would do it a little bit differently. There would be group work and discussions and activities, and we've obviously had to amend the session for the online platform. So instead, as I mentioned, we're going to be using sort of the discussion board and chat box function quite extensively, so we can all talk together, even if we can't hear each other's voices. So I'm going to start with a short presentation on incorporating gender analysis into research. Then we have 5 case study presentations with discussion and activity, and we're going to end with a short group discussion. But before we move on to these activities, I'd like to start by introducing each of the panelists. This is myself, Rosemary Morgan. I'm on faculty at Johns Hopkins Bloomberg School of Public Health in the United States, but I'm originally from Canada. I work as a gender advisor on multiple projects, including the UK Partnerships for Health Systems program, and also a project on sex and age differences in immunity to influenza, as well as 2 projects on gender and COVID-19. I'm going to move on to my next presenter, Zara Zaineli, and let her introduce herself. Zara, over to you.
Thank you. I'm trying to start my video, but it seems like I don't have permission. Anyways, I'll start. Hello, everyone. Good day. Very happy that you've made the time to join us for this skill building session. I'm Zara Zaineli. I'm a medical doctor from Iran, and I've studied public health at Johns Hopkins, focused on health systems research and gender specifically. Currently, I'm serving as a fellow with the Rockefeller Foundation, Boston University, Commission on Health Determinants, Data and Decision Making, and I'm volunteering as a researcher with Global Health 50/50 for the past 2 years, working on gender equality. My area of interest is gender, intersectionality, and health equity, and happy to announce that I've been selected to the newest cohort of this conference's Emerging Voices for Global Health. I'm looking forward to having a fruitful discussion with all of you.
Great, thank you, Zara. And Shreytush, over to you.
Good morning and good evening from different parts of the world. Welcome to our session. My name is Shreytush Wong. I'm currently a policy manager of Enhancing Quality of Healthcare Activities project funded by USAID in Cambodia. I'm also a former research fellow for Rebuild Research Consortium and RINGS, the Research for Gender and Ethics. And I'm actually the former Emerging Voices 2016. Actually, my area of interest are around the health system research and genders. some other area of interest is around the public health issue like water sanitation, nutrition, reproductive health. Yes, really happy to be here and hope we can move on together for the whole session. Thank you.
Thanks, Ritush. And last but not least, Faro.
Good morning to everybody. My name is Faro Bwese. I worked for Chipaiko here in Liberia as the gender focal point. Here I worked with the HRH project, where in Liberia here we were able to do the first gender analysis in pre-service education. Of late, we also conducted a study that we'll be presenting today, looking at improving the management capacity of female managers in our health facility, a project organized, implemented, funded by GIZ. I'm really interested in improving the capacity of female managers in Liberia because we know that Africa, when it comes to female managers, they are few in numbers, especially in the health setting. So I'm happy that you are all available today to our presentation. Thank you. And over.
Thank you. So let's get started. We have a lot of content to go over in a short time. As I mentioned earlier, I'm going to start with a brief 30-minute overview of gender and gender analysis, just to situate ourselves in thinking about how can we integrate a gender and equity lens into our research, but specifically today talking about our human resources for health research. So what is gender? What do we mean by gender? Well, this definition here comes from the World Health Organization, and it defines gender as socially constructed roles, behaviors, activities, and attributes that a given society considers appropriate for men and women, as well as gender minorities. So gender does differ from sex, and sex is more related to biological characteristics like hormones and genes, for example, where the main difference is gender is socially constructed. So gender operates on various levels simultaneously. If you look at the pyramid here, at the bottom of the pyramid, you can see that gender influences how society is organized more broadly in terms of social norms, institutions, structures, resources within all social systems. So that's families, households, communities, economies, and states. Gender also encompasses interpersonal relationships between individuals. So gender very much is about power relations, and it does govern a lot how we interact with each other, how men and women interact, but also how men interact with each other and how women interact with each other. And also gender forms individual identities and values, who I am as a woman, how I define myself as a woman, how a man may define himself. On the left here, you'll see that gender is negotiated by individuals and societies. It changes over time and across contexts. This is a very important point. So gender is context specific. What it means to be a man or woman in one country or context is not necessarily the same as what it means to be a man or woman in another. In addition, what it meant to be a man or woman 50 years ago could be very different from what it means to be a man or woman today. So gender is fluid, and what it means to, gender norms, roles, and relations change over time. Another very important point is the fact that gender interacts with other social stratifiers. So this is bringing in that intersectional lens or intersectional perspective. So it's the idea that we can't treat all men the same, and we can't and shouldn't treat all women the same, because gender interacts with things like class, race, education, ethnicity, age, geographical location, disability, and sexuality. Also professional candor is what we'll be talking about today. And really, to really bring in a gender lens and equity lens to our work, we must have this intersectional perspective. Here's just a brief definition of gender analysis. So gender analysis is defined as the process of analyzing how gender power relations affects people's lives, creates differences in people's needs and experiences, and how policies, services, and programs can help to address these differences. So it's not only understanding how gender power relations affects people's lives, but then also thinking about what can we do about it. There are three broad approaches to gender analysis that I like to distinguish. And when you talk to different people, they'll have different words and definitions for these. But in my own work, this is what I teach in my gender analysis class as well. There are these sort of three approaches, and depending on the research you're doing or the intervention program, some of this might be more relevant for you compared to others. So that first one, the gender analysis of context, this is sometimes referred to as gender assessments. This is when you explore how gender inequalities or inequities within a context may affect an intervention or may affect research. So implementation research, for example, would fall under there. So this is a discrete piece of work. I might go into a country context, do a gender analysis of that context or a gender assessment, and then from that assessment, ask questions like how might the context, the gender norms, roles, and relations in this context affect my research or affect my intervention, and what might I need to do to adapt accordingly. Whereas the next one, this is a very much studies where the aims and objectives focus on gender. So right from the very beginning, you're wanting to understand what gender norms, roles, and relations how they might affect a specific health or health systems issue, like human resources for health. And the last one, this is one where I think most research falls, and a lot of donors now are asking us to bring in a gender lens, an equity lens to our work. So this is incorporating gender into existing interventions or existing research. So asking, well, here your aim and objectives of your study might not be related to gender, but you need to ask key questions related to gender within your data collection and analysis. So let's go over the gender analysis activities within the research process. So this is an important important sort of figure that we want you to have a look at, because the activity that we're going to be doing later on, you're going to need to be thinking of this particular frame or this particular figure. So what you can see is that it uses the World Health Organization gender assessment scale. On the right here, you'll see 5 stages of research. So we've got gender and equal research. This is research that actually perpetuates gender inequality by reinforcing unbalanced roles, norms, roles, and relations. You'll see gender blind research. So this is research that completely ignores it, and often gender blind research can lead to gender and equal research. Then you have gender sensitive and specific research. So both of these consider inequality generated by unequal gender norms, roles, and relations. The main difference is, whilst gender sensitive research considers it, it doesn't take any action to address it. Whereas gender specific research does take action. And that might be in the form of advocacy, making recommendations, policy recommendations, changing programming, for example. Whereas gender transformative research, this is research that actually seeks to challenge and change inequitable gender norms, roles, and relations. So what you'll see on the left, on the blocks here, or the pyramid, however we'd like to refer to it, there are different activities. And these are the activities that you can incorporate into your research to make it gender sensitive, to make it gender specific, or to make it gender transformative. And they build upon each other. So at the bottom there, you see the do no gender harm, making sure that we're not perpetuating unequal gender norms, roles, and relations. And then you see different activities, and I'm going to go through just a few of these today because we don't have time to go through all of them. But the key takeaway message here is that to be a gender sensitive research, you really need to do, all or most of those activities at the bottom of the pyramid. And then gender specific, you've got to do all or most of those activities at the bottom, plus the ones in the middle. And gender transformative encompasses all of this. So things like desegregating our data by sex and other social stratifiers, using a gender analysis framework, developing an intersectional gender analysis matrix, including gender sensitive questions in our tools, and considering gender in our data collection processes, incorporating into our analysis plans, engaging relevant stakeholders, and then at the top, here also thinking about, if you want to be transformative, the methods that you use become very important, whether they're sort of participatory methods. So let's get started. I'm just going to highlight a few of these today because we don't have time to go through all of them. So the first one is desegregating by sex and other social stratifiers. So this is really kind of the backbone of gender analysis, but it is not gender analysis. So just by desegregating our data by sex or other social stratifiers, that is not gender analysis. So here I have the difference, or I may defined sex and gender specific versus sex and gender desegregated. So the main difference between those is where sex and gender desegregated analysis, that might be research that includes both men and women. So if you're doing human resources for health research, you might be doing it with physicians and then comparing women and men physicians, for example. Whereas a sex and gender specific analysis, that is an analysis with just women or just men. So you can do gender analysis with a study that looks at a specific gender. You do not need to desegregate between men and women to do gender analysis. But so desegregation of data is an entry point, for further understanding. It's very important. It helps us see where differences are, but doesn't necessarily explain why those differences are there. And that's where the gender analysis comes in. So desegregated data that is intersectional looks at differences among men and women and people of other genders. So if I was doing a sex or gender specific analysis, I would might desegregate my data by age, disability, race, depending on my context, to look at differences among. And like I mentioned before, I think in order to do gender analysis appropriately and adequately and correctly, we have to bring in that intersectional lens. As I mentioned, desegregated data, it acts as a trigger, and it's not gender analysis. It just helps us to understand where differences are. And this is very critical, as aggregated data sets, that's data sets that combine everyone together, can mask differences between and among men and women and people of other genders, which is a bias that can negatively affect the validity and reliability of our research evidence. It also means that whatever the findings are, you're attributing them to everybody. And is that correct? And who is everybody? Everybody tends to be the norm, whatever the norm or status quo is, which in many contexts is white males, or in other contexts, males. So this is really important that we do not aggregate our data sets. So moving on to using a gender analysis framework. Again, this is really the backbone. We're sort of still at the bottom, the foundation of the pyramid here for doing gender analysis. And gender frameworks are always the place that I go to start when I want to do a gender analysis. So gender frameworks act as analytical guides. They help us to further organize our thinking, frame our studies and questions and data collection and analysis. It really is, we're using sort of recognized frameworks about the ways in which gender power relations and gender inequities manifest. Frameworks are used to both classify interventions in research, but also to guide interventions in research. And I'm going to just be going over briefly today a few of those so you can see the difference. So firstly, using frameworks to classify research. There are two main frameworks, and this sort of brings them both together when you're looking, from gender unequal to gender transformative human resources for health research. I already presented the one at the top there, the WHO assessment scale. And then we also have this continuum at the bottom that looks at exploitative, accommodative, and transformative research. So let's just go and look at those in more detail. So this comes from a manual from the Interagency Working Group on Gender, and it's the IGWG Gender Integration Continuum. The next slide goes into these in more detail, so I'll stop here. This is really good for interventions or good for research that is more intervention based as well. So this is helpful because it allows you to sort of situate where your research is. Is your research gender blind? Are you completely ignoring gender, or are you being gender aware? And if you're being gender aware, are you being exploitative, accommodative, or transformative? You want to avoid being exploitative if you can at all costs. This is research or interventions that actually reinforce or take advantage of gender inequalities and stereotypes. And we do see this a lot in sort of public health messaging. So messaging around family planning, for example, that might capitalize on masculinities about men's sexual prowess, for example, and telling them to make sure they get tested or to make sure they use protection. So what it's doing, it's reinforcing this sort of form of masculinity, which actually can be harmful in order to meet its public health objective. The one in the middle, accommodative, this works around existing gender differences and inequalities. So this is about, we're recognizing that they're there. We're recognizing that there's differences between men and women, and we're adapting our interventions or research accordingly. Whereas transformative, this again seeks to challenge or change inequitable gender norms, roles, and relations. And it's very much a lot about the methods and methodology that you use. This is the WHO assessment scale. We already went over this, so I'm not going to go over it again in more detail, but just wanted to put it up here. So you saw it again. So that's one type of frameworks. So frameworks to classify our research. There's also frameworks to guide our research. And this is really a lot of where I start off at. So we can use these frameworks to inform and develop gender-aware research. So what they recognize and what they do is they recognize that that there are key aspects of gender power relations, which they are identified across main dimensions of social life. And such frameworks then facilitate the data collection and analysis of how those gender relations operate. They help us to clarify how gender differences might create constraints or opportunity for men and women and boys and girls, identify whether there are any specific gender-based structural institutional constraints that might affect the opportunities and status of men and women. And it helps us to move beyond simply desegregating data by sex or other social stratifiers. Remember, the data desegregation helps to see where differences are, but doesn't really necessarily explain why those differences are there. And that's where the role of frameworks come in. Here are two frameworks that I really like to use. They're very similar. The first one on the left is one that we published in our paper, How to Do or Not to Do Gender Analysis in Health Systems Research. And the one on the right is from Chapago, and that's their gender analysis framework. They look at very similar domains. There's just one key difference. So the one on the left asks questions about who has what, who does what, how are values defined, and who decides. So thinking about how do gender power relations or gender inequities manifest as an equitable access to resources, division of labor, social norms and beliefs, and rules in decision making, for example. The main difference is the Chapago framework has another domain that looks at institutions, laws, and policies, which I think is very helpful for contextual research. So if I was doing a gender assessment, I would use the Chapago framework. However, if I was doing sort of interviews with key players, I may not want to be, that broader contextual level may not be as relevant. The other big difference is the Chapago framework has power directly in the middle, and as it should be, because power is very much cross-cutting, whereas the one on the left sort of brings that out, but with the recognition that all of these domains are interrelated and cross-cutting. So move on, you can see I'm skipping a lot of steps here just because we really don't have time, and we also want to make sure we have enough time to go over different case studies and to really talk about where those case studies fall along this continuum. Just want to say before I move on to this next one of the another really important activity that I think for incorporating a gender lens into our research is the third one. So the developing an intersectional gender analysis matrix. And there are resources online to help you do that I can point you to. So this sort of takes the framework, the gender analysis framework, combines it with key domains related to whatever your research is, and then starts asking questions that are relevant for gender. And then the next step is now collecting data and information on those questions. But you can see there's all these different activities. What I really want you to pay attention to for our activity moving forward is the bit on the right-hand side, these 5 stages. And what does it mean to be gender unequal? What does it mean to be gender blind? What does it mean to be gender sensitive? What does it mean to be gender specific? And what does it mean to be gender transformative? That's what I really want you to focus on. But before we move on to our activity, just a final few slides thinking about gender transformative research, because at the end of the day, this is what we all strive for. I mean, not all research can be gender transformative, nor should it be. But if we're going to have long-lasting change, we really need to have that transformative aspect. So what is gender transformative? What is a gender transformative approach? Well, these are research programs and interventions that create opportunities for individuals to actively challenge gender norms, promote positions of social and political influence for women in communities or other marginalized groups, and address power inequities between persons of different genders. They often create an enabling environment for gender transformation by going beyond just including individuals as participants. So individuals become actual collaborators. There's a lot more engagement and participation throughout the process. What's really important are the methods when we're thinking about gender transformative research. They often include interactive awareness building or educational activities to foster critical awareness of existing norms, roles, relations, and inequalities. They create space for community engagement and debate. They facilitate discussion of how gender norms, roles, and relations might advantage or limit one's opportunities. Are participatory. So participatory methods will often highlight the centrality of power and challenge implementers to reflect on and redress power imbalances within interventions or researchers. So it's bringing in that idea of positionality. Who are we as researchers? Who are the participants that are engaging with us? Where does the knowledge really lie? And trying to kind of balance that and challenge that, the sort of the status quo on how research is typically done. So by doing that, by actively involving participants in the process, we can engage participants to act and reflect on self-identified problems and issues. And you've probably heard of, participatory action research, and bringing a gender lens, or feminist participatory action research is actually a specific type of that looks to and seeks to challenge and change existing gender inequities. So I would like to move us on to our activity now. This is a skills building session, and I think we need to work together in order to build those skills, not just have us talk at you. Unfortunately, we are unable to hear your voices today, but we plan to hear your voices in the chat box. So please do get your fingers ready for the next part of the activity. What I'm going to do is I'm going to stop sharing my slides and ask the HSR to share for us instead, and then hand over the next session to Zara for the next presentation.
Thank you, Rosemary. If I could also start my video. Okay. Perfect. I think, yes, excellent. My audio and video are both working. Perfect. Thanks again, everybody. And thank you, Rosemary, for the introduction to the workshop. As she mentioned, now we're going to present a few different case studies. These are based on papers that have been published or papers that are almost being published, so studies that have been done already. We'll present them one by one, and then we look forward to hearing your opinion on where does this study lie across this continuum of gender, from gender unequal to gender transformative. So the first study that I will be presenting is a study based in Vietnam, job motivation of rural health workers in North Vietnam, done by Dillman et al. In 2013. Next slide, please. So to set the scene and the background and the introduction of the study, it starts with the fact that within a well-functioning health system, the health workforce is an important pillar. The motivation of the health workforce is a crucial factor in their performance. In Vietnam, 80% of the population live in rural areas, and therefore it's important to have extensive public health networks within those rural areas in order to provide care to people within an appropriate distance. At the time of the study in 2003, most of the Vietnam public health staff, about 84% of them, were already working in rural areas, but there were still some vacant posts, and the posts that were not vacant and were occupied, oftentimes were occupied by health workers with a mismatch in their skill or their qualification or even their motivation. And then we'll move on to kind of understanding that obviously it's really important to, in order to provide good quality healthcare systems, healthcare services, apologies, it's important to develop strategies in order to influence and increase and improve health worker motivation, for them to have a better performance and for them to provide better care. Next slide, please. So the methods of this study. This was an exploratory qualitative study. It was conducted among healthcare workers in North Vietnam. The health workers were from different categories. I'll mention them in a moment. And the study was done to identify entry points for developing strategies that improve staff performance in rural areas in Vietnam. The aim of the study was to determine the most important and major motivating factors, and it was the first study looking at this issue in Vietnam among the health workers. Apart from the health workers that were included in the study, so by health workers, we mean the first line. There were some managers at the provincial and national level who were also interviewed as part of this study, as well as some community representatives. The interviews were semi-structured. They were conducted with the following categories: 14 men who were all policymakers and managers, health staff that were working at the district or community level, 25 in total, 15 men, 9 women, members of a team called Hygiene and Preventive Medicine, 12 people, 12 public health workers, 11 community members, and additionally, 4 public health workers at the district level, and 4 additional community representatives were interviewed. The interviews, when they were being conducted and the group discussions were happening, they also used some visualization tools in order for the participants to be able to weight their the different factors that they identified for their motivation. Yes. Next slide, please. Then we move on to the results of the study. So the study shows that Motivation among these health workers in North Vietnam is influenced by both financial and non-financial incentives. The main factors that the health workers identified that improved their motivation was being appreciated by their managers, colleagues, and the community that they're serving, having a stable job and a stable income, having training that's appropriate for the service that they're providing. And the factors that discouraged them and demotivated them was usually related to low salaries and difficult working conditions. The interviewers and the people who conducted the study found no difference in the points of view of about motivation of health workers among the different levels of health workers that I just introduced, nor did they find any difference between men and women. And then the authors in the result say that this is either true or we did not probe enough to find those differences. And then the study recommends, in order to improve staff motivation for improved performance, the health system should consider financial and non-financial incentives, and then also improve performance by including the health workers in the designing and definition of different health workforce management tools that will be implemented to improve this motivation and staff retention at their posts. So this was the first case study. Now our question to you, next slide please, is to take a moment and think through everything that Rosemary mentioned and decide where does this study lie across this spectrum or this continuum that we've provided here. In order to do this, you can go to the platform. There's a poll option there, and just pick and choose whichever you think is most appropriate for this study, but you can only choose one. And I think you can take a minute or two to just think through how you want to put this across this continuum. So was the study gender unequal? Was it gender blind, gender sensitive, specific, or transformative? Excellent. I am seeing um, 31 people have voted so far. So let's wait. Okay. I encourage everybody else to pick one of these 5 options on the platform. We have 45 votes and 127 participants. I think we can also move to the previous slide, the results, so that the participants, thank you, can have a look if it helps them decide. Okay, perfect. So thank you. We have 51 votes so far. If I'm not mistaken, you can also see the percentages on the platform yourselves, but 6% have voted the study is gender unequal, 43% have voted gender blind, 38 gender sensitive, 9% gender specific, and 4% gender transformative. Thank you to everybody who participated. Can we move to the next slide? No, the previous one. Okay, perfect. Thank you. This one. Excellent. So we have 43% gender blind, 38% gender sensitive. Now, if you don't mind me, I wonder if the people who have chosen gender unequal, the 7%, could you or would you like to share why you've decided to land the study on that end of the spectrum? You can just write a few lines or words in the discussion forum. And once I hear from a few of you, then I can move on to the next part. Any thoughts from the gender unequal voters? Okay. How about we move on to some of the 45% of participants who voted gender blind? If you would like to elaborate in a few words or lines in the discussion forum, why you decided to select gender blind.
We have a quiet group today.
We do. No answer is wrong. Okay, I think we have a few. Oh, no, we have more than a few now. I'm struggling to keep up. Okay, so first one, gender blind, and oh.
I'm not seeing them.
It's on the platform in the discussion forum. I'm trying to start with the first one, but now we have a lot of them just bumping up and down. Okay, so I'll read a few. The intervention was developed for both men and women, but did not take into account the gender specifics of how the workplace impacts women. Gender blind, from your overview, it appears gender was not considered in the study design. Gender blind because the results appeared that the option given did not include gender into account, the gender specifics of how the workplace impacts women. The study did not specify gender of the workforce. Issues considered don't appear to consider norms, roles, and relations. I think the article authors themselves admitted that issues around gender, I lost that comment, were not probed much. And then the last one, none of the results seem to refer to gender-related causes of motivation. Perfect. Then if we could hear a few comments from the 36% of participants who selected gender sensitive, and then I think it's safe to move on to the next part. So I'll give one more moment for the gender sensitive voters. So we have a response who says, I think gender was explored with sex disaggregated data, and there's some reflection that the research didn't fully explore the sex disaggregated perspectives, therefore gender sensitive. Another one, I think the study tried to consider gender norms, but it couldn't address the gender inequalities. So I think it was gender sensitive. Okay. Okay, then, perfect. I think it's safe to, I'll read the last one and then, yes. In my point of view, the study included in the design, the gender and the detailed hypothesis, the authors referred to the internal gender issues that may explain differences in the motivation of health workers. Okay, perfect. Well, thank you everybody for participating in the discussion. I know this is a first for all of us to be at a workshop but not be able to speak. But thank you nonetheless for your motivation to join the discussion. So as a preamble, as Rosemary also mentioned, it's important to know that this is a continuum, and there are no really clear lines that we can define. This is definitely falling into this bucket or that. And it's also a matter of perspective. So this whole skill building session is going to just give us an idea and some tools to hopefully move across the continuum. Okay, we have put this. Yeah, go ahead.
Can I just jump in? Sorry. Yeah, I just was reflecting on wanted to reflect on some of the points that came in on the discussion forum, because I think there were some really interesting comments coming in. And I think as Zara said, this is a continuum, and studies may fall, some aspects of the study may fall in one part, some aspects may fall in another. I would agree with the participants who put the study under gender blind. And it is a fairly older study. We have, and it was done, some time ago, and the study specifically looked at the motivation of healthcare workers. They did explicitly look to disaggregate data by men and women. However, in the study, they said that they didn't find any differences. And what I like about this particular study is it shows us that, we need to do more than just disaggregate data if we want to bring in a gender lens. We need to ask specific questions related to gender, because if you don't ask those questions, you're not going to find differences. Because men and women, healthcare workers, are likely to have different motivations. And they're likely to have a lot of similar motivations. But if we're not asking questions that are specifically related to gendered norms, roles, relations, we're going to miss those. So it's just not enough to disaggregate data. So bringing in one of those sort of gender analysis matrix, and then thinking about creating gender analysis questions, incorporating those into our guides, that's how we get at those. And I think we do need to move on to the next case study soon, but Zara, but I know there's a question for you to answer.
Absolutely. Thank you, Rosemary. Yes. So in conclusion, we did put the study as a gender blind study for you. Now, if the main question is, what are the activities needed to move this research along the continuum from gender blind to improve it to sensitive, specific, or transformative? Please take a moment and write down what you think would help this study to move along this continuum. Oh, I muted myself. Okay, so I'll go through your interventions on what you think are the activities needed to move this study across the continuum. Look at what are the specific challenges to employability pertaining to men and women. Specifically explore the gender dimension of health worker experiences. Perfect. Use a gender analysis matrix and incorporate more of an intersectional lens. Have a focus group discussion with women workers before making the tool to understand the issues and develop a gender-based questionnaire. Engaging with underlying contextual norms and stereotypes that underpin motivation. These are all really excellent interventions. And I think any one of these or a combination of these could definitely improve this study and move it from gender blind. As Rosemary just mentioned, it's really important to have this aspect in mind before defining the research question and defining the study design in order to make sure that, especially in the health workforce, which is highly feminized, there are different gender norms and roles that we need to take into account. There are a few questions coming in. I'm not sure if we should move on to the next case study or address those questions.
Let's move on to the next case study because we do have 5 or 4 more to get through, and we have a record of those questions. And at the end, I think some of the discussion will actually answer and get to some of those. But please make sure to keep posing those questions. And at the end, during our general group discussion, we'll come back to them. So if we can move on to the next slide, please. Great. So Shreytush, over to you. Oh, we've lost the slide sharing. Great. And Shreytush, if you can just unmute yourself, and it's over to you.
Hello, can you hear me all?
Yes, thank you.
Yes, apologize that I have to turn off the video because of the internet speed here is not stable. Yes, now let's start with the case study from Cambodia. So just for your information, this is the mini case study that was done in 2015 under the funded from DFID UK through Ring Consortium. Next slide, please. Just for your, let's start with the perhaps the a little bit background of Cambodia. Actually, Cambodia is situated in Southeast Asia, neighboring with the Vietnam, Thailand, and Laos. Currently, Cambodia population is about 15 million. Yep. For the health sector in Cambodia, as the background for all the participants, the Cambodian health sector started to be reformed in since 1996. But after the almost two decades of the health system strengthening and human resource development and reforms, the current health system employ around 20,000 health workers. Nevertheless, like the gender imbalance between different category or between the imbalance of the genders in the different profession in the health workforce is still a critical issue for Cambodia health system. Mostly women were underrepresented in high level or what we call like high skill or clinical skill or leadership level of the Ministry of Health structure. For example, if you look at the right-hand side of the graph, these are the graph that shows the number of women in leadership of the current Ministry of Health structure. If you look at the last bar chart, you will see that all the senior staff including male and female at sub-national and national level, you could notice that women only represent about slightly over 10% of the total number of senior personnel in health workforce in Cambodia. So this case study, as said earlier, has been conducted in 2015, which aim to identify the barrier and enabling factors for career progression of Cambodian female health workers toward the leadership level. Next slide, please. This is a purely qualitative case study using in-depth interview with the adoption of the life history method with 20 health manager, basically the manager of the health clinics of the operational health district of the provincial health department in all structure of the MOH in Cambodia. We did the interview with 20 participants, 14 female and 6 male in 2 operational health districts in 1 province of Cambodia. Participants were purposely selected based on various criteria, including age, service date that they start, I mean the entry point that they start, the skill or profession, position, and leadership progression. Next slide, please. So let's start, let's move on to the findings. As said, because the case study basically try to identify the barriers and enablers. Now let's start with the barrier. As Rosemary said, gender actually shape all levels of the society. Started from the macro level, social norms in Cambodia, where mostly view that women are not considered to be a suitable person for decision making and leadership level or leadership position, while men perceive to have longer and more strategic vision than women in that position. This is the clear highlight from the interview. Second, in the meso level, the work-life balance is a critical issue for mostly that all the female leaders face. For example, like the balance between managerial roles of being a female leader in the health workforce versus having to balance the domestic chores, including caretaking of children and elder at the household level, is one of the critical area that most of the female manager highlight in the interviews. It's also the lack of male support in the organization or institutions level. Most of the female leader highlighted that there seemed to be a lack of support from male colleague or male supervisor to be more supportive for women in the leadership position. At the micro level or what we call individual level, most of the interview happened or most of the information obtained from the interview shows that the perception of limited capacity and managerial capacity and plus the personal traits of women actually influence the confidence and that those kind of skills actually influence the confidence and make women more reluctant to take on the more responsibility in a higher level, like become a leader or manager of a local health facility or local operational health district. And it's also those kind of skills like capacity, technical skill, managerial skill, and personal trait also influence the respect, the level of respect that women obtain from their position. Next slide, please. I think just move on, please, to the next slide. Next, please. Yeah, in terms of supporting factor or enabler for women in leadership, we found at the macro level, though the history of Cambodia and the journey of women in leadership level started in very early stage when the society is not open, But at the moment, we can see some change. The Cambodian society is more open for women to participate in the health workforce, but still biased toward the male leadership. At the meso level or institutional level, we can see or we observe there are some gender mechanism. For example, we can see the national and provincial government structure have become more gender sensitive. They have what they call gender working group in each province to support the women to be in the leadership position. We also find a very positive deviant case study that more local male manager also tend to support women in the early stage of their career pathway to be the leader of the local health center as well. At the micro level, we also obtain some information on the technical and managerial capacity of the women actually determine the success and confidence of women. And we also see that the current women who are becoming the leader of a local health center or local health facility tend to experience strong support from their family and their male partners who always provide more opportunity or to support women to be in leadership position. Next slide, please. So for our recommendation, we, from the case study of Cambodia and also perhaps the other health system globally, we thought that the strategy to promote equity in leadership within the health workforce need to be implemented at all different levels. At community level, the gender roles norm within the family and community need to be challenging and need to be changed. At the individual level, self-motivation, support from family and especially the male partners and appropriate capacity and qualification of female provider all empower women to break through the glass ceiling to be the woman in leadership. Last, at the health system level, policies are needed which support women advancement within the health workforce. Just for your information, this case study have been disseminated through the presentation at various international conference. Also, we also put it, writing the blog and put on the RINGS website. And also we one paper purely provide the detail of the findings was published in a journal of, I think the BMC journals. Yes, so that's all for the presentation. And I just want to go back. Rosemary, do you want to jump in or do you want me to continue? Because I did not see the pool.
Yeah, no, I know, Shritish, you're having a hard time seeing the platform. So I can help with moderating this next session. I'm also a bit conscious of time. So we're gonna, we've got quite a few case studies to get through, and we want to really talk about, you know, where on the continuum they lie and why and what we could do to increase their sort of the gender lens. So if you can move to the next slide, please. Just take a moment. There should be another poll that you saw to vote where you think that this presentation that Shritush presented fits on the continuum. Is it gender unequal, gender blind, gender sensitive, gender specific, and gender transformative? The votes are coming in. I've got 7 votes, 11, 14. I'm not sure if can the participants see the votes as they come in, or do we have to share the results? I'm assuming we have to share the results. So I'm just going to give it a couple more minutes, or a couple more seconds, not minutes. Minutes are a long time when you're in a forum like this.
Update.
Got 29 votes. All right, I'm going to give it 10 more seconds and then I'm going to share the results.
Wow.
Alrighty, and share. So Nobody said gender unequal. Nobody said gender blind. Straight to 19% said gender sensitive, 55% said gender specific, and 25% said gender transformative. For those that said gender sensitive instead of gender specific, could you just quickly take a moment to write why that is in the discussion forum? See, I still see some votes coming in, which is good. So please take a moment to say why you put it at gender sensitive instead of gender specific. And those that put gender specific, please do write in the discussion box, in the chat box, why you put it there. What were your reasons? I'm gonna just have to refresh my page. That's the only way I can see if there's new things coming up. So one person said that gender transformative was when recommendations kicked in. Someone else said I put gender sensitive because the underlying power relations, while identified, were not changed. Thank you for these reflections. Someone else has posted the not transformative in their point of view, in a sense that no actions have been done in the favor of changing the norms and structures of the leadership positions. Someone else wrote that it was gender sensitive as an initial point to gender specific and then transformative. Yes, I think it's really depending on the types of activities that you put, that you integrate, of where your study falls on the continuum and how to move it up. So Shretush, oh, here's one more that says that gender specific, because it does take into account the enablers and barriers that influence women's health workers, their work across the micro, macro, and meso level, but recognizing them does not transform into changing the status quo. So Shretush, where would you put your study on the continuum?
Thank you, Rosemary. The technical issue of the chat room. Yes, for myself, I would say that this is the gender-specific case study because basically in the early stage of the design, I actually embedded the idea of exploring the gender differences in the case study design, even in the design of the tools for the interview. And last but not least, the result of this case study was actually been used almost as the advocacy tool with different level of the different group, for example, like with the international conference targeting policymaker and those kind of academia. But yeah, I would say it's a gender specific, but I'm not quite sure whether it how to move it to the gender transformative part,
So why don't we ask the participants, how would you move this study to be gender specific to gender transformative? What do you think Shretush could have done to move it up? I'm not sure if I see. Zara, if you see any responses that I don't see, do pipe in, because sometimes I have to refresh the page to see any.
Sure.
Yeah, I'm trying to refresh.
Here we go. It came up. Yeah, we've got, someone says that I believe more discussion with policymakers at the national level, advocacy and engaging high rank policymakers. I did see there's a comment in the question and answer that I think is really relevant for this particular point. Oh, we've got some more coming in, which is great. Sharing the results of interactive workshops, high level advocacy, mixed gender group sessions. see. I feel gender transformative are more long-term interventions that bring change over a long time. Maybe things move from being sensitive to more transformative takes time since norms and values are not easy to change. Yes, I would agree. Pascal had mentioned in the question and answer that the reality is that to be transformative, there needs to be some flexibility built in, which makes the research action-oriented and responsive, and often public health methods are too rigid to enable this. We need to be reflective and responsive if we want to be transformative. Yes, I think these are all great points. I think that the points about, just sort of presenting the results at high level interactive workshops wouldn't necessarily make it transformative. You could potentially challenge and change an individual view in that, but it's that long-term sort of flexible nature that's important. It's engagement right from the beginning to make it transformative. And I think like if you're interested in doing a gender transformative study, you really need to build that in from the beginning. And I saw that Tolib had a really relevant question as well, that do all research need to be gender transformative? And the question is, the answer to that is no, absolutely not. And not all, I mean, yes, we want to strive to challenge and change unequal gender norms, but the reality is it's not appropriate for all research. I would say that all research should strive to be gender sensitive at a minimum, because if you are gender blind, you risk being gender unequal. So you risk perpetuating unequal gender norms, roles, and relations. So we should, at a very minimum, disaggregate our data, integrate specific gender analysis questions or gender questions. I think we need to move on to the next case study now. So thanks Shreytush for that. That was excellent presentation. So next slide, please. So this is one, I'm going to go over this one very quickly because I want to make sure we have more time for the final two case studies I think are even more interesting. So this is not a paper of ours. This is another one that we're presenting. And this is the implications of the feminization of the primary care physician workforce on service supply. This was a systematic review, and we wanted to include this as a specific type of research methodology that often a lot of us do use. So next slide, please. This is just the background over the paper. So the reason that they did this study is because the workforce in many industrialized nations is increasingly female. I think a primary care physician, the health workforce is predominantly female in many contexts, and we're seeing physicians, the gender nature of physicians change in a lot of contexts. And it's doubling. We see more women going as students, for example, and it's only expected to grow. So next slide, please. So this was just your typical systematic review. I'm not going to go into all of this. If you know what a systematic review is and how to do a systematic review, this just goes over that. You'll see that they ended up including 34 articles in the end. They used words like primary care, women, manpower, supply and distribution in their search. They included things like years of practice, hours of work, intensity of work, scope of work, and practice characteristics in this in the general findings. So next slide, please. So here are their results, and this is where I think it gets kind of interesting. We have self-reported fewer hours of work. So compared to their male colleagues, female physicians had self-reported fewer hours of work, had fewer patient encounters and deliver fewer services, write fewer prescriptions, see more female patients and fewer geriatric patients, and provided less out of office and off hours care. So next slide, please. So they concluded that the feminization of the workforce is likely to have a small negative impact on the availability of primary healthcare services as a result of those findings. This is what they've concluded. They also included that it is important to consider effects of childbearing and child rearing, which were mentioned in several studies, but were seldom explicitly investigated and were not the primary focus of any of the research documents. And the true scale of the impact of findings on future effective physician supply is difficult to determine without really with the currently available evidence that's what we always say at the end of systematic results, don't we? More research is needed. But if you can just take a moment, so next slide, please. If you can just take a moment and say, where would you put this study on the continuum? Thanks, I see some votes coming in. Oh, we've got lots of different opinions on this one. I'm just going to give it a little bit more time. Please do put in your vote. Where do you think that this study falls on the gender continuum? Great, I'm going to share the results. And then as I'm doing, please do in the chat box explain why you voted where you voted. So as you can see, 12% has said gender unequal, 16% has said gender blind, 16% gender sensitive, 40% gender specific, 15% gender transformative. So we have all across the board here. So please take a moment and do put in the chat box and the discussion forum, why did you place the study where you placed it? And make sure you tell us where you placed it so we'll be able to see as that comes in. Zara, are you seeing anything come in?
Not yet.
Okay, I'm just worried that things are coming in and I'm not seeing them. Nobody wants to explain? I guess because no one actually really feels they comfortable know where they put it. Okay, we got one. Yeah, thank you. So Anna says that the findings reinforce existing gender prejudices, do not seek to understand underlying reasons or factors. Yeah, I would agree with that, Anna. Rumi says that gender unequal, it did not do anything for gender, closing on the note for need for more research. If there was an option for anti-gender, I would select that. Thanks, anti-gender. That's another category we should add. Zia says, because of the basis of the study selection, we can design the interventions. Zakaria says, even though it has explored the feminization of the workforce, it does not explore the power dynamics and inner inequality issues. The systematic review is not the best useful in exploring these power dynamics and causalities, maybe other types of reviews. Yes, Carrie, I think what you've hit on the exact reason why we wanted to include this study here, because we do use systematic reviews a lot, and systematic reviews are often considered kind of the gold standard, aren't they, in research. But when we're dealing with things like power and power relations, you know, they're really not the most appropriate methodology. And I agree with Anna, and I agree with Rumi that I would actually put this under gender unequal, even though there might be components of it that we could argue fit somewhere else on the continuum, because I think it potentially perpetuates existing gender stereotypes, and it actually can have what it could actually be doing is harming perceptions of female physicians. So and I think sometimes our methodologies are very limiting, and this is an example of how we can unintentionally actually be gender unequal in our research if we're not careful. So let's move on to the next slide, please. So Zara, hand it over to you to study this. Just be conscious of time. Thanks.
Thank you. So this is a study that we did, an intersectional study of enabling and hindering factors of career progression among health workers and healthcare managers in Kenya. Next study, please. Sorry, next slide. Quick background, Kenya signed a new constitution in 2010, and they moved from a centralized governance system to a devolved system. It allowed the local officials to have more authority to appoint and elect leaders and managers. Another part of the newly signed constitution was references to gender representation, both in the elected and appointed leadership, and calls for improved gender representation. This study explored the pathways for health workers in Kenya to progress towards leadership levels once this decentralized system was implemented. Next study, please. Next slide. Ooh. Sorry about that. Okay, so this study was also an exploratory qualitative study. It was undertaken in 2 different locations in Kenya, urban setting Mombasa and semi-rural setting Kifili. In total, 25 healthcare managers were interviewed. 4 of them were at the county level and 21 at the sub-county level. 13 were women and 12 were men. There were in-depth interviews, and the health workers were at different levels. I'm not going to go through the levels again, but they were well represented within their levels of authority. And then the interviews were transcribed and coded according to an intersectional framework. Next slide, please. So, as the study was on the enabling and hindering factors for health workers' progression towards management in Kenya, the interviews identified some of these factors. The main themes that emerged from the interviews included family support, mentors, financial support, and self-determination as factors that enabled the health workers to move up. And the hindering factors that the health workers alluded to included financial limitations and domestic responsibilities. And then there were also unique experiences created for the career progression due to the intersection of some social stratifiers and identities, such as the intersection of age, gender, professional cadre, ethnicity, or the tribe that they belong to, their financial status, and education. So, next slide, please. You know the drill by now. Can you please fill in the poll? Where do you think this study lies across the continuum? Okay, let's wait for 15 more seconds to get some more votes. Okay, we have 20 votes. Nobody has voted for gender unequal, 14% for gender blind, 33% gender sensitive, 48% gender specific, and 9% gender transformative. So let's invite a few of the people who voted for gender specific instead of gender sensitive to share their thoughts in the discussion forum. Now we're having more votes, so the percentages are changing. I think you're able to see 40% gender sensitive, 44% gender specific? Would love to hear from you on your thoughts, why this is either sensitive or specific.
Sensitive and specific are neck and neck.
Reminds me of another recent example of neck and neck. Okay, perfect. So we have one answer. The focus, Zachariah is saying the focus on the hindering and facilitating factors look in causal powers underlying lack of access to leadership position, but the line is quite blurry. You're right again. Allison, the intentional exploration of intersectionality was the tipping point for me to put it into gender specific, but tricky to be sure. Yes, thank you. You're also right. So now we have 42% gender sensitive, 42% gender specific, and by definition, they're incredibly close. By definition, they're incredibly close in terms of how we can identify these studies. But I try to present the study in a way that we can categorize it as gender sensitive. And I think I'll just go ahead and say that if we wanted to make it more gender specific, the extra step that we could have taken would have been to, because in the study we considered the inequalities between men and women health workers, and the study also alluded to the gender roles and norms and expectations. I wasn't able to go into enough detail that kind of create these experiences. But then if we wanted to make it gender specific, it would be helpful to come up with certain recommendations or specific set of suggestions in the results or in the discussion where for either the healthcare managers or the policymakers or future researchers. So with this study, we ended the gender part of it in the result, and we just mentioned what the study had found, but we didn't really suggest anything on how to tackle these unequal norms. So I'll just stop here, and hopefully we can move on to the next one.
Just to say, Zara, that Suja has an interesting comment. She says that this to me seems like a great example of how merely having a written policy for bringing gender transformation is probably not enough. I don't know if you could speak a bit more to that. What do you think, Zara? And it'd be interesting, Suja, if you could expand on that comment, that would be really interesting. Why is not having just a written policy for bringing gender transformation not enough?
Yeah, thank you for your comment, Suda, and for raising this, Rosemary. I wasn't able to see it on the forum. I think that's exactly correct. I think that one of the benefits of a workshop like this is to understand the range of options that we have and be able to incorporate as much or as many that we're able. Oftentimes we see that providing some lip service or some written policies is considered as, well, it's better than nothing. And the reality is that there are concrete steps that can be taken to transform these dynamics beyond just writing. So for instance, what comes to my mind is engaging the relevant stakeholders, including the study participants, in these discussions in order to make sure that the recommendations are being implemented or being considered, and sort of also important to move beyond the bubble of research and make sure that the results of the research are being communicated to a wider audience and are being implemented across different sectors. I'd love to hear what your thoughts are as well.
Great. Sorry, Shatish, did you want to come in there?
Yeah, sorry.
Go ahead.
One quick comment, perhaps it's also about the methodology of the research, perhaps the participatory method where we could bring in the policymaker and also study participant to expose to the context of gender norms and how it affects their reality or real life, would also another platform to perhaps moving from the gender sensitive or gender specific study to the gender transformative.
Great. Yeah, I would definitely agree. And Suja has expanded on her points in the chat. So she says, I thought it was a great example. For instance, it is easier to make a policy that includes women or tries to change power relations, but both women and men need to work on this change. So tough and tricky to implement.
Yeah.
A written policy is the first step, but policies, sorry if I pronounce your name wrong, Sarab says policies are eventually implemented by the people who are part of the society and have similar norms and beliefs rooted in patriarchy. Thus, the way policy is envisioned and the way it is implemented could be poles apart. Would definitely agree. Great. I think let's move on to our final case study and hand it over to Varo, who's going to take us home and as well lead us through the final discussion. So Varo, next slide, please. And Varo, over to you.
Okay. Hello to everybody. So I'm from Liberia again, and I will be discussing a case study, a curriculum to foster women's leadership in Liberia health sector, the Health Facility Leadership Program. Next slide, please. So Liberia is in West Africa, and over the years, the percentage of female health workers in Liberia has increased. In 2010, there was 68% of health workers who were female, but by 2016, according to the Health Workforce Census report, 45% of the health workforce were females. Although there was this increase, but according to the general analysis from the Health Workforce Census, women were unrepresented when it comes in leadership and management positions in the health sector. Few examples are given here in the slides. At the National Public Health Institute, there were 11 directors, and of those 11 directors, there were only 2 who were females. Liberia has 15 counties, and each of those counties have what we call county health officers. County health officers are people who manage the health services or the health system at those counties level. And of those 15 county health officers, there were 2 who are females in 2016 when this report was written. And there were also 3 who were also health administrators. And then for the community health department, there was no female as county health pharmacists, no female as county monitoring evaluation officers. And these positions are like the top management positions at the county level. So you have few females represented at those levels. So this study sought to improve the personal and technical leadership and management skills of health workers. And the study participants were 75 health facility managers. Health facility managers are people who work at the facilities and they oversee all of the activities at the facility. So the study participants were 75 health facility managers. The focus of this study was to improve the capacity and leadership management of those health facility managers. So to be a part of this study, you have to be working at the health facility. And if your county was selected, you have to be once you are a female and working in a health facility, you were selected. Next slide, please. So the method we used, it was a linear approach. We had a training-led discussion. It was group-based. So in each of the counties, we have 15 participants. And of those 15 participants who were female managers and 10 participants were male. So we have different cohort in each county, and we did this project in 5 counties in the southeastern region in Liberia, the most hard to reach and difficult counties in Liberia. So as I said, 15 female and 10 male in each of the cohorts. So we have 50 female participants and 25 male participants. Another approach was the individual coaching, where the facilitators or the coaches were assigned to participants. And after each of those workshops, we had the one-on-one coaching sections with those participants to enforce the learning from the workshop so that when they get back to their facilities, they can be able to duplicate those skills that they have learned at the workshop. And they were also, each participant also had to develop a project at the facility to carry out. We also conducted mobile coaching. So while participants were on the study period or the rest period, the coaches will also make telephone calls to follow up with them, just in case there were issues that they had or questions that they had in implementing the different projects at the facility level. And the participant will also call if they have problems. So it was a two-way, although we set up time to call them, but then you could call anytime, you could call your coach anytime, just in case you have issues. And then what we also did was we provided support for the participants after each section of the workshop. There was this management cycle meeting for female participants in each of the workshops. So female participants had their own group. Female participants had their own group, and in that group, only female participants were in that group, and we had this discussion looking at issues at the workplace as managers, and then we discussed how we can or how those issues can be resolved, and how women at the workplace can be able to build their own capacity so that they can be able to go to a higher level of to a higher managerial level, or enhance their skills in management so that they can be seen as someone who is potential to occupy a management level position at the county health team or even at national level. Next slide, please. Okay, so this was about the management cycle that I've talked about already. And then at the end of the day, each workshop, we had self-study period, which was 5 to 6 week self-study period that the participant will go back to their facilities. And then after that time, they come back for another workshop section. So each cohort had 3 workshop sections, 3 management cycles meetings, 3 coaching sections, one-on-one coaching sections. And then each of them have 5 to 6 weeks of rest period between each of the workshops. Next slide, please. Okay, so sorry, the result is not on yet. I will just say it. I know you all are listening. So at the end of this workshop, we were able to develop a module curriculum for health facility managers in order to enhance or build their capacity. We were also able to complete the training of 49 female participants and 23 males. So one of our participants dropped from the female cohort and then 2 from the male cohort. And we were able to conduct all the 3 rounds of coaching section with the participants, and also we were able to also conduct the 3 management cycle meetings. What happened was that at the end of the management cycle meeting, the female participant thought that it was very good and it even helped to build their managerial skills. So they themselves went back to their counties and also established this management cycle meeting for other female participants within their network. And in 3 of the counties that we were working in. And then at the end of the whole cycle, some county health teams saw the potential, or that some of those health facility manager skills were built. So like 3 of our female managers or female health facility managers were elevated to another level as district health officer. District health officer is like someone who controls the whole district. So 3 of our females participants were elevated to that position. And one of our participants, a female participant, was also given the opportunity to go for further studies to enhance her skills. And then all of our participants were certificated. So that was the study looking at fostering women leadership here in Liberia. So if we go to the pool, Zara. Hello?
Hi.
Okay, can you help me with the pool there?
Sure. So if
Yeah.
everyone can take a moment to please vote on where you think that this study lies on the continuum. We'll just wait a moment for some of the votes. Some people were voting as you were speaking, and they were sometimes some of their votes changed as you were speaking. So I'm going to share the results, but people, I believe, can still vote as I do. Ashwari is asking if we could go back to the finding slide, but unfortunately, this is a slightly older version of the PowerPoint that didn't make it. I mean, I could share my screen with the finding slide if you would like. I do have it. Would you like me to do that? So if you could stop sharing your screen for a moment, I am going to share mine. Here we are. There you are. So here's the slide. Here are the finding slide that, sorry, what didn't come up. So if you take a moment to vote, you can see some of the results there. I'm going to stop sharing so we can I can have a look at what's coming in, sharing the results. So Varo, we have 59% of people said it was gender transformative, 35% said gender specific, 4% said gender sensitive, and we have 4% said gender unequal. So if you could just take a moment, please, to explain why you put why you ranked the study where you ranked it in the discussion forum. And just give people a moment to collect their thoughts and give their. And then, Vara, I'm not sure if you can see the discussion forum, so I can read off what's coming in.
Yes.
Yeah. And so why did you place this study where you placed it? Nothing's coming in yet. Oh, there is one that I missed. Sorry about that. So Zakaria said, I would say gender transformative, as it is design and action research cycles that is about changing mindsets and works and leading to behavioral changes and structural changes in healthcare settings. So for example, capacity building session at the district management teams. Someone else. So Lauret says there is a deliberate effort at achieving equity and equality from the baseline. That was not so. And Elisa says it's interventional, so it seems transformative, but no details on sustainability were shared. So maybe depending on future plans.
Okay. Should we stay with a little bit more?
Yeah, we've got, so Zia says in the COVID-19 crisis, the study much more effective if we design to see changes in health-seeking behavior in men and women equally. Wesam says it informed policy and practice, though some actions taken with a specific focus on women managers and how to build capacities regarding their leadership and managerial skills, so it is gender transformative. And then Allison asks a question, can you have gender transformative research design without first having a gender analysis? So Vara, if you want to, tell us where you think, where in the continuum would you place this study and why, and while responding to some of those comments.
So yes, I totally agree with those who put the study on the transformative end. And it's because if we look at the methods that we use, during the management cycle meetings, we look at what are those norms, what are those cultural beliefs, or what are those practices that prevent women from excelling into management capacity, what prevented them, and were able to discuss it and build their capacity to see how they can move further into their management skills, how they can build their management skills, their managerial skills at those levels. Another thing that we also did was when those people were on their self-study period, the study also worked with those managers to see how at that level their capacity can be built, how they could be able to organize meetings, how they could be able to do different projects that they will be able to see and then improve health services at those levels. So all of those different things, for me, I think that this study was more of transformation, because we tried to move them from that manager who wanted to be seen as the most liked but never wanted to be assertive also. We're able to move those female participants from that level to another level where they would be able to see themselves as a manager who could actually manage the health facility. And then we were also able to even work with policy members. At the end of the training, we had a dissemination section or a resource section, that I would call it. And at the resource sections, we're able to present the resource to the different policies managers, to the different managers, the CHOs, and even people at the ministry level, to see how these people had transformed from one stage to the other. I totally agree when it comes to the issue of sustainability. This project really did not look at the sustainability of the project, and I think that was one of the recommendations, that the Ministry of Health also look at it more, so that they can be able to sustain those gains that were made and even build on it for other counties and see how they can also use other managers to help build their capacity. So I think it's more transformative, although we need to do some other, there was other recommendation. What we did not do, we did not ask the male participants, like in a group discussion, to ask them what are some of the things they thought that could help female managers to excel. So we left them out in the sense of that management or that focus group discussion. They were not part, we never had any section with them. And I think maybe for further time, if we want to implement it again, we should have a separate session for women and a separate session for men, where we'll be able to see more those norms and those values that people look at, and when they are thinking about appointing people in managerial skills or managerial levels. So I think it's more transformative.
Great, thanks, Varo. I haven't had any other comments come in when you're saying, so I think we do have some final discussion questions, but before we move on to that, I think some of the points that we wanted to get across with these exercises is, it is very important to integrate gender and gender lens into our research, because while health systems are not gender neutral, they are products of the environments and societies in which they exist. And if we see gender inequities and inequalities in different contexts, we're going to see them in the health system, and we see them within human resources for health. We see that clearly with the studies that Zara and Shretush and Varo presented today, and that we need to aim at a minimum to be gender sensitive. And to do that it's about, yes, making sure we're desegregating data appropriately, but that's not enough. Making sure that we are integrating gender questions. And we do that by using gender frameworks, gender analysis matrices, for example. The key difference between gender sensitive and specific, like they're very similar, and it's sometimes really hard to disentangle one from the other, is just sort of going a step further to actually do something about our research, which we should all be doing anyways. I mean, that's just good practice and ethical practice to make sure our research doesn't just sit on a shelf. And I think we presented some of the case studies today. You didn't have all the information. We left out some information to help facilitate the discussion a little bit as well. We did that on purpose. But I think what all research, try to be gender sensitive, but we need to also kind of move to be specific. So how can we change some of these inequities that we're looking at? And then for gender transformative, you really need to think about how you're going to integrate gender from the very beginning if you want to seek to challenge and transform existing gender inequities. The methods, as Varo presented, the methods become so important. Participation becomes so important. It is often more long-term. Someone mentioned in the discussion board that norms are very hard to change. That's true. I do think that, you know, if you want to have transformative intervention, you really need to integrate gender right from the very beginning. In research, doing those gender assessments of the context become very important. I know JPIGO does that in the context that they work as well. So to understand the underlying gendered context and then think about what interventions are needed and what can be adapted. So can we move on to the next slide, please? Great. So Vara, I'm going to hand it back over to you to lead us through this discussion.
Yes, so for our next slide, we are going to use the pool again. So we'll ask these questions and then you can just use the chat box. I mean,
just the chat box, no pool.
Yes, the chat box. You can use the chat box to just write the responses and then we can all discuss it. So our first question here is, how will you integrate gender into your own research? So can we just read all the questions and people answer, or we should just do it one at a time?
Just let people in. We only have 9 minutes. Let people answer what they'd like to answer. Yeah.
Yes. So you can just answer to the different questions. So our second question is, what are some of the key challenges to integrate gender into your research? And what are ways you can overcome these challenges? So please make use of the chat box and then you just put the responses and then we can all discuss. Thank you.
Yeah, I'm particularly interested to know, based on our discussion today, what are some of the things that you're going to do moving forward to integrate gender into your lens research? And then what might be challenging for you to do so? Like what are some of the challenges that you think might come up?
Yes, I think those are the two key things.
Yeah. So I'll keep an eye on the discussion forum to see what comes up. Nothing yet. I think that people are thinking, and sometimes it takes a little while to type it out, and then they all come up, and then it's hard to read them. All right, here we go. Claire says, one challenge is that donors may not always accept to cover costs related to additional analyses or efforts associated with taking a gender transformative approach, or they will require additional advocacy to accept covering these costs in anything more than token terms. Does anyone want to comment on that? I would agree with that comment that often, especially when we want to take more transformative approaches, the way that the funding structures are right now aren't accommodative for that. Often we need more than 1, 2, 3 years to do this. It's also really sometimes hard to measure change, transformative change as well. And the M&E that we have, existing monitoring evaluation structures, aren't really conducive for that. That is definitely a key challenge that I found in my work as well. Anna says that I am doing some work right now around HRH MIS and wanted to understand how to factor in gender. I think that routine data can be a trigger. Maybe some frameworks or analytical tools can be a good complement to foster gender sensitive data analysis. I would agree with that as well. I think you can do existing and gender analyses of gender analyses of existing data sets. I mean, obviously it may not be as robust if you didn't incorporate it in right from the very beginning. But again, remember, sex desegregated data can act as a trigger. Bringing in that intersectional sex gender desegregated data as well can act as a trigger. And then I have used in past, I've used the gender frameworks and gender analysis matrices to devise relevant gender analysis questions to incorporate into sort of health information surveys. And then from that did a gender analysis of the desegregated data. Because remember, desegregated data tells us where gaps might be, but doesn't necessarily help to explain why So Zia says, I particularly need a framework and the cost to cover gender into research and time allocation. I agree with that, Zia. I think often the times we're not given adequate resources to be able to do it. My recommendation would be using a gender framework and gender analysis matrix as a step. And I did include some resources at the bottom. And we also have some resources slide, and I know these slides will be shared. So you can go and see additional resources. TDR, which we were part of, recently published a toolkit on integrating an intersectional gender lens to infectious diseases of poverty research, which goes over a lot of what we were talking about today and what a lot of our case study presenters today did as well. So we've got lots more coming in. Ashwarya says integrating gender in research requires multi-level stakeholder engagement, which poses questions on feasibility and funding since it requires multi-interventions. Yes, that's very much a challenge. I agree. Zia says gender-based intervention studies need more time to change societal norms for the favor of gender transformation. I would agree with that as well. Definitely agree with that. Very much a challenge. We need more time to be able to do this. It's long term, and our current, like I said before, our current structures aren't always suitable for that. Zachariah says it starts by including a multidisciplinary teams in the research projects. Yes, I agree. Then the design should be triggered in a way to include gender equity underlying theories whenever it is appropriate. However, I believe that carrying a whole new research question or including gender analysis during the analysis afterward. Yeah, I think if you can, I think that it's best to try to integrate gender from the beginning. I mean, it's not always possible. We can do gender analyses of existing data sets. It'll just be, there'll be limitations. But if you can incorporate that from the very beginning, and using gender frameworks, using gender analysis matrices are ways to systematically allow you to do that, to make sure that you're covering across the different gender dimensions and asking the right questions and not missing anything. Sorry, I think I heard I'm not sure who that was.
Yes,
please go ahead.
This is straight to Rosemary.
Yeah, go ahead.
I just would like to add, perhaps from my perspective and experience of doing that gender study, actually doing the gender, one of the main challenge of doing the gender research is also how do we as the researcher to break the power relation between our team, our project, our institution, you know, when we try to say that incorporate gender in the early stage of the study design, but considering the context, like for example, if you are a gender person in the team and you have to challenge the power of decision making and with your whole team, your supervisor who are male, and at the same time, because gender is also seen as additional component, additional thing, it's not like embedded in the process of doing research. So whenever we want to integrate gender, mainstream the gender in the research design, they always come back to us like, this will be an additional component, this will need additional resource and support. So coming back as the reflections, I feel that doing gender study, embedded gender analysis in our research is also I mean, we as the individual researcher also have to play with the power relation in within the design of the study and challenging this with the whole team and whole organization as well. So
great.
Yeah.
Thanks, Shritush. I think that's really really great reflection. We're just coming up at the hour, and I wanted to see Zara if you had any final words, and Varo if you had any final words. Zara?
Thank you. I think everything that needed to be mentioned has already been done, and I'm afraid this session will just end automatically instead of us ending it. But thank you everybody for your participation, and I hope that this helps you all to incorporate a little bit of a gender lens into your future research and interventions.
Great, and Varo?
Yes, so I want to say thank you to everybody for participating. And as we've said, if you want to move more towards a gender transformative program, you should start at the right beginning of the program. Try to integrate or analyze gender do some gender analysis so that you can be able to know what are the issues, then you can be able to address it in your programming, and you can go forward into a gender transformative.
Yeah.
Yeah. Thank you. Thank you all. And thanks everyone for joining us today. Really appreciated having your collaboration, your discussion, and your engagement. And please, I hope you enjoy the rest of the conference. Thank you.
Thank you.